Hello, everyone. This is Dr. Bishal Gyawali from Queen's University, Kingston, Canada again. Today's video is specifically targeted for trainees from low and middle income countries. I have been in touch with several trainees from LMICs, and one of the commonest questions I get are in my interaction with them, one of the commonest issues I see is about how to practice evidence-based medicine from theory to real clinical practice. And I think one common factor is that in LMICs, we are not trained about evidence-based medicine. We simply practice based on what we call eminence-based medicine or textbook-based medicine. If there is a certain disease, we try to read about it in our textbooks and then try to learn what the right treatment for that patient is. Or we learn it by looking at our seniors, what they're doing, and we try to do the same thing, which is not bad in itself, but I think as a medical oncologist or as any physician for that matter, we need to know the evidence behind every intervention that we're doing. So if there is a patient with colon cancer and we are planning for adjuvant chemotherapy, we need to know why we are offering FOLFOX. We need to know why we are offering 6 months or 3 months of FOLFOX and what the differences are. We need to know the data behind every intervention. We need to know what is the risk of recurrence if we do not offer FOLFOX at all or any chemotherapy at all. What is the risk of recurrence if we give chemotherapy for 3 months? What is the risk of recurrence if we give chemotherapy for 6 months? And does that extra benefit is congruent with patients' threshold for accepting side effects? So we need to be clear about those metrics, and we need to be able to tell the patient about those metrics to help them make a decision. And how do we know about these things? We know about these things by reading the clinical trial that is supporting this data. For example, why not offer FOLFIRI in an adjuvant setting for a patient with colon cancer? Why not aid bevacizumab or cetuximab in adjuvant setting for a patient with colon cancer, but why to aid the same drugs in metastatic setting? What does the trial show? What was the trial like? And what type of patients were included in the trial? And what were the outcomes? What should we do for stage 2 cancer? What should we do for stage 3 cancer? What's the difference between offering capecitabine plus oxaliplatin versus FOLFOX? I'm just giving an example from colon cancer, but the same principle applies for every cancer. The fundamental principle is we need to know the trial behind every intervention, and we need to know that trial outcomes in detail, what type of patients were included, what the outcomes were, so that we are confident in our decision making and in talking to our patients that this is what's going to happen if we don't do anything, this is what's going to happen if we do something, this is the optimal thing we can do, and this is what's going to happen for the optimal thing, and these are the side effects that can happen, so that the patients are able to make an informed decision. We don't use a treatment simply because our professors are doing it or our mentors are doing it. We see that they are doing it, and then we go back home or back in our office and then try to dig up the trial that led to that decision. And sometimes the mentors may not be right as well. It's not necessarily that the mentors are always right, and you can debate about it, you can think about it, because everyone has the same resource. The mentor is also going to read the same trial, and you are also going to read the same trial. There is an extra trial that is made for the mentor that you don't have access to. Everyone has access to the same resource. So you need to know. So evidence-based medicine is a combination of expertise, which comes with age and experience, plus the evidence, the trial data that teaches us what is the best thing to do in a given scenario. So for that matter, I highly encourage the trainees to read each and every trial that is affecting your clinical decision in your everyday clinic. That's the best way to become an oncologist. That's the best way to become any physician, to know your data well. And for that matter, one good advice might be, as you are starting your training, let's say you just joined your oncology residency or fellowship, then I think it's a good idea to have like a Word file or an Excel file, whatever you are comfortable with, where you have a link, or if you are good with reference managers like EndNote or other softwares, where you put a PDF of the given trial. So as you are doing your training, make a resource that is a collection of all the important trials in that particular cancer type that you can always quickly go back to and refer whenever you need. Of course, I don't expect you to remember all this data in day one or month one. So you need to go back and like even senior people, they don't remember everything on the tip of the hand, but they just remember the ballpark figures. And to get an exact number, there should be a resource that you can quickly refer to. Like every time, if you think about, oh, why should not FOLFIRI be using adjuvant setting, or what's the data for 6 months versus 3 months of Kpox, then every time you should not just Google that and try to find the paper and then read the paper. That's time consuming. So if you have a resource where you have stored all of these important trial information or the trial PDFs for easy access, then it makes your life very easy. But the bottom line message is, don't just follow what others are doing blindly. We are physicians. We should be trained to look into the numbers and understand the numbers and not just blindly copy anyone. So find trials, make a collection of the important trials in your particular field, and have it easily accessible wherever you are. That's my important take-home message. I hope this message is helpful for trainees.